Hi, my name's Audra Sloan, and my Capstone project is over decreasing hospital-acquired infections. We're going to start off with a few statistics here. Approximately 687,000 healthcare associated infections in acute care hospitals in 2015. Of that, 72,000 deaths occurred from these HAIs. Now, at the magnet facility in southern Indiana that I've been researching, we only have yearly education and competencies and online care learning. So I don't think that's enough. And we only have education on how to apply the isolation precautions. The CDC recommends that we have unit-specific education and training on transmission of infectious organisms for all employees, and then ongoing education programs. And this includes nurses, aides, dietary, the environmental services, everybody that works here, everybody that has any patient contact. And it's important that we provide visitors and the patients with handouts about hand hygiene, respiratory hygiene, how to cough into their elbow and not just spray it everywhere. The visitors that we have, they rarely ever put on the gowns or the masks, and I think that spreads it to the rest of the community when they leave. And actually, we need education on what type of isolation diseases need. There's some debate on like RSV. Different people think that RSV is droplet versus contact or both. We need clarification on that. The problem is healthcare associated infections are defined as infections patients get while receiving healthcare caused by bacteria, fungi, viruses, or any other pathogens. 1 in 31 hospitalized patients have at least one HAI, the CDC says. Negative outcomes that can come from an HAI include patient illness or even death, prolonged hospital stays for antibiotics, additional diagnostic and therapeutic interventions, which equals added costs for all the patients, and nobody wants that. All nurses have had a patient that's been in the hospital for a longer time, and they contract a PICC line infection or port or Foley infection. So it's something we need to crack down on. My literature review consists of a few different studies that I looked over. The first one, they did pre and post education surveys to get this information. They assessed healthcare workers' awareness of infection prevention, and findings concluded that the policies that we already had needed strengthened, or if we didn't have one, then we obviously needed a policy that talked about preventing HAIs. The next one conducted a survey that identified 4 issues that affect adherence to isolation precautions. We all accidentally walk into an isolation room without gowns or gloves on that we should. And that includes low risk perception, like not knowing why we put these on, the weakness in knowledge, insufficient training, and infrastructure limitations. This points out the need for the organizations to make us do more in-service training and education on this. The next study pointed out that we need to crack down on hand washing. They implemented a hand washing protocol and observed a whole year of the rates of their hospital-acquired infections. And they did this by auditing the nurses' documentation. The nurses had to document whether they washed their hands, whether the patient washed their hands. A lot of the times, staff forget that patients need to wash their hands too. They go to the bathroom and just walk back because they have an IV in their hand and don't want to get it wet. And it showed that there was a positive correlation between hand washing rates and decreasing the hospital-acquired infections. The fourth study consisted of strategies to prevent these hospital-acquired infections. This included the education for all the staff, which I've mentioned, a hand hygiene campaign, a clean environment for our patients, chlorhexidine bathing, which we've implemented at this magnet facility, and active surveillance. Cotter's 8-step change model proved that this remarkably reduced the incidence of infections. The last one, this is kind of a random study, but it just assessed times necessary that the environmental services uses to clean patient rooms when isolation precautions were in place versus not having isolation precautions, whether they're taking more time to clean when there's isolation precautions, like if you have a sedated patient, they should probably spend a little more time wiping everything down. They did that by collecting data from 72 different organizations, and I think that was in Canada, and results concluded that isolation rooms took significantly longer to clean than no isolation rooms. So my PICO question was, would quarterly unit-specific education programs on staff infection control practices compared to only new employee orientation and annual online refreshers help decrease the incidence of hospital-acquired infections? So the problem is obviously hospital-acquired infections. The intervention that we would use would be the quarterly education for all staff members on the use of infection control practices, compared to what we're doing now is only education at new employee orientation and yearly online refreshers. And hopefully that would decrease hospital-acquired infections. The theory that I used for this was Nightingale's environmental theory. It recognizes how to alter an environment to affect a patient's health. Examples are fresh air, pure water, sufficient food, and cleanliness of the patient and environment. An unsanitary environment should be altered to improve health and allow patient healing. Like we use sterile procedures to keep bacteria out of surgical sites and infection-free. Isolation precautions alter environment by providing cleanliness for patient and staff. And I brought some little gowns in here that we're supposed to use here. These help protect you from the C. diff patients. Now obviously gloves, they help with everything. And then masks will help with flu precautions. So we just want to alter the environment and keep our patients safe. The research proposal would be an experimental quantitative research design in a medical surgical pediatric unit at a magnet facility in southern Indiana. It would include all hospitalized patients in a 6-month time frame. Staff would be given education on the isolation precautions, and rates of the hospital-acquired infections would be observed for 6 months post-education aim compared to the previous 6 months before the education. Data collection and analysis. The data that would be collected would be objective data, the increased temperatures, heart rates, decline in blood pressures. Then diagnostic tests could be used to confirm the infection from objective data. Sorry, this is very uncollaborate, whatever that word is. Data would be analyzed using an unpaired t-tests to measure the mean incidences of HAI in the 6 months after education compared to the 6 months before. Data analysis would help determine whether quarterly education would help decrease incidences of HAI. And the conclusion is that hospital-acquired infections cannot be completely prevented in certain situations, but it's the responsibility of us to help alter the environment and keep patients safe. Quarterly education that is unit-specific and performing hands-on competencies can help improve the rates of HAIs and help protect patients from unnecessary infections. And that's it.